I am Varun Puri. I am a professor of surgery at the Washington University in St. Louis and a practicing thoracic surgeon and health services researcher.
As with any major oncologic resection or other major surgery, lung cancer surgery can be associated with a risk of minor or major complications in the early postoperative period, as well as some adverse long-term outcomes. Fortunately, in general, with the advent of minimally invasive surgical resection, the likelihood of both minor as well as major complications after surgery has diminished markedly. When one looks at literature over the last 15 years, the likelihood of minor complications is in the range of 10 to 20%, and the rate of major complications all put together is just a little under 10% in recent studies. Minor complications really do not prolong hospitalization or adversely affect patient outcomes in any meaningful way, while major complications can at times prolong hospitalization. Just to enumerate a few complications which can occur after any major resection for lung cancer, these can include things which are well recognized, such as atelectasis, which means inadequate expansion of lung with inability to clear secretions, bleeding, which can occur after any operation, air leaks, which are a complication which are somewhat unique to patients undergoing lung resection. Patients who undergo, say, a lobectomy, segmentectomy, or wedge resection for lung cancer have their lung parenchyma divided using a stapling device. A stapling device does two things while it's being used. It divides lung tissue as well as seals it shut at the same time using multiple rows of staples. Most patients have a small degree of air that leaks from the lung for a short period of time in the early postoperative period, usually 1 to 2 days, and then that subsides. Patients have a chest tube that stays in place while that is occurring, and as the air leak subsides, the chest tube can be removed. A small proportion of patients, probably about 5 to 7%, particularly those who have diminished lung function, severe emphysema, or are smokers, have a likelihood of prolonged air leak, which may necessitate leaving a chest tube in for longer, or occasionally patients going home with a chest tube. Other complications can include the risk of pulmonary embolism, deep vein thrombosis. Atrial arrhythmias are also a complication which is somewhat unique to patients undergoing major thoracic surgery. These are largely paroxysmal supraventricular tachycardias or atrial fibrillation. These occur between 5 and 20% of times after major lung resection. In most instances, they require management with medications, which are often beta blockers or other antiarrhythmic agents, and do not require placing the patients on anticoagulation. And almost universally, the arrhythmia has disappeared by the 3 to 4 week mark when patients are seen in follow-up. Myocardial infarction or other cardiovascular complications such as stroke. Renal failure is also a complication that can occur after major lung resections. Unique complications after any major thoracic surgery, fortunately seen rather rarely, is chyle leak. Chyle is fluid which is lymphatic in nature, and the thoracic duct, which carries chyle or lymph from the abdomen through the thorax to its eventual drainage site in the left subclavian vein, traverses the posterior mediastinum. So in the process of lung cancer surgery, where one performs an extensive mediastinal lymph node dissection or resection, in that case, one can notice chyle leaks. This manifests itself with a high chest tube output, and the chest tube output becoming cloudy or milky when patients eat fat-containing food, because chylomicrons and triglycerides from the lymphatics in the abdomen are absorbed, traverse the thoracic duct, and may leak in the chest in patients who have a chyle leak. Fortunately, this is a very rare complication after major lung cancer surgery. Additionally, wound complications, which can be either superficial or deep wound complications, can also be seen. Fortunately, again, they're seen very rarely in thoracic operations as opposed to abdominal operations. Pain is also an important facet that has to be dealt with in the postoperative period. Patients who undergo thoracotomy for lung cancer resection often require placement of an epidural catheter or other interventions to prevent postoperative pain. A small proportion of patients present with what's called chronic post-thoracotomy pain or chronic post-thoracotomy pain syndrome. This is associated with neuralgias of the chest wall and manifests itself as dysesthesias or other abnormal sensations of the chest wall, which can occasionally be a troubling symptom long-term in a small proportion of patients. The likelihood of major complication as defined by the Society of Thoracic Surgeons in today's day and age is relatively low. It's under 8 to 10% all put together. The likelihood of mortality in the current day and age for patients undergoing surgery for early stage lung cancer is in the range of 1% or less. And in general, both those numbers have been declining over the years with the advent of robotic assisted or video assisted thoracoscopic surgery. And these days, the vast majority of early stage lung cancer operations are performed in a minimally invasive fashion, which is one of the main reasons to adopt minimally invasive surgery, to lower the likelihood of short-term complications after surgery. It's also important to note two other important components when one talks about complications in the perioperative period. The first of these is which patient is at a greater risk of postoperative complications. So there are well-defined risk factors for major complications after lung resection. These include increasing age, diminished lung function, the presence of peripheral vascular disease, continued smoking in the perioperative period, congestive heart failure, low albumin or other diminished nutritional parameters, and low functional or exercise capacity, which is noted in the perioperative period. So it's important to identify patients who may have a higher likelihood of perioperative complications and either direct them towards prehabilitation or other forms of optimization prior to surgical resection, or have a discussion about the risk of surgery associated with major resection in these individuals. When one assesses or manages complications after surgical resection, an important emerging concept is rescue of patients from these complications. And conversely, the failure to rescue patients from these complications. Patients who have major complications after any major operation have a higher likelihood of mortality. This has been shown in many studies, both retrospective and prospective. However, institutions which have a higher likelihood of case volume or experience in managing complications in the postoperative period have a greater likelihood of rescuing these patients and avoiding postoperative mortality despite the occurrence of these complications. Since this is an emerging concept, we are learning more about it, but volume and experience of institutions are the two main parameters that have emerged in our ability to identify institutions where rescue of postoperative complications is successful. Wound complications after any major operation can be either superficial or deep wound complications. Superficial wound complications include minor breakdowns or superficial wound infections, which typically require either opening up part of the wound with some wound care and often do not require either prolongation of hospitalization or any antibiotic therapy. However, deep wound complications are a bigger problem. They are associated with deep wound infection, which require either wound debridement or opening up the wound with either wound vac therapy, in addition to administration of intravenous antibiotics. Deep wound complications are often associated with either readmission or prolongation of hospitalization. Fortunately, both superficial and deep wound infections are relatively rare in major lung resection operations. Another infectious complication which is important is the occurrence of postoperative pneumonia. As one might imagine, patients with lung cancer with diminished lung function and smoking status are predisposed to a higher likelihood of postoperative pneumonia after any major surgery, particularly lung resections. The likelihood of postoperative pneumonia is in the range of 5 to 7%. There are many things one can do to prevent postoperative pneumonia in the postoperative period. These include smoking cessation, and our group has done some preliminary work where we've shown that improving oral hygiene using a chlorhexidine mouthwash 3 to 5 times a day for 5 days preoperatively may also potentially lower the likelihood of postoperative pneumonia. We performed a pilot study in this field and are looking at performing a larger multi-institutional study to confirm these preliminary findings. This is because many postoperative pneumonias are related to oral organisms which are aspirated in the perioperative period, leading to lung colonization and infection.